This is the last video in a series on syncope. We're going to talk about the tilt table test. We're going to talk about the summary of everything. Just as a way of reminder, we've said that there are two major causes of syncope. One is a neuro cause. The other one is a cardio cause. The neuro cause usually has a prodrome. The cardio causes are usually unexpected and have no prodrome. With each of these causes, we broke them out into two subclasses. So we had the arrhythmias and the structural defects with cardiovascular system. With neurological system, we had orthostatic syncope and we had reflex syncope. The reflex syncope further subdivided into four categories. There was vasovagal syncope, situational syncope, carotid sinus syndrome syncope, and then non-classical syncope. The non-classical meant that it happened because it was a reflex syncope with an unidentifiable cause. Reflex syncope is excess of parasympathetic nervous system. Orthostatic syncope is a defect in the sympathetic nervous system. And then with the arrhythmias, we said we can have tachyarrhythmias and we can have bradyarrhythmias, all kinds of arrhythmias. With structural, those structures usually happen inside the heart, whether it is some valve being stenosed or some kind of tamponade or some kind of PE or pulmonary hypertension, or you can also have extra cardiac causes that are vascular only, such as aortic dissection and subclavian steel. We don't want to forget about the old classic traumatic trauma causing hemorrhage. Okay, so that's the overview. Let's go back and talk about the tilt table test first. So what we're looking at with the tilt table is, as a person is on the tilt table, is there a change in their blood pressure? Is there a change in their heart rate? Do they have a prodrome? And do they lose consciousness? By these four variables, we can look at and identify a lot of different things. So if the blood pressure drops significantly, but the heart rate is relatively unchanged and it may even increase, there may or may not be pre-syncope, but there is a loss of consciousness. You diagnose reflex syncope, and it is a vasodepressor subtype. Alternatively, if there is a relatively unchanged blood pressure, but there is a significant drop in the heart rate, with or without pre-syncope, there is a loss of consciousness that is diagnostic of reflex syncope, and that is the cardioinhibitory subtype. If there is a significant drop in both blood pressure and heart rate with or without pre-syncope and with a total loss of consciousness, that is a mixed type, cardioinhibitory and vasodepressor. Now imagine we went through this same paradigm with all of these blood pressure and heart rate changes, except for, in this case, there must be a pre-syncope and there cannot be a loss of consciousness. Then it would be suggestive of reflex syncope but not diagnostic. If there is a progressive decrease in blood pressure, but the heart rate remains relatively unchanged, a progressive decrease in blood pressure may or may not have pre-syncope, may or may not have total loss of consciousness, but you would diagnose orthostatic syncope if there's a progressive decrease in blood pressure. Now, if the blood pressure doesn't change and the heart rate doesn't change, there may or may not be symptoms of pre-syncope, but there is a loss of consciousness. Nothing changed, nothing caused a decrease in cerebral perfusion pressure. That is most likely psychogenic syncope. The only other possible explanation would be that you have four vessel stenosis. You have both carotids and both vertebral arteries are completely, more than 50% stenosed. And that would be a loss of consciousness because due to the change in the amount of energy needed to get the blood to the brain. But in general, this is going to be psychogenic syncope. Now, blood pressure is unchanged, but the heart rate increases by more than 30 beats per minute, or the total heart rate is greater than 120 per minute within a 10-minute window. There may or may not be pre-syncope. There may or may not be loss of consciousness. This is a diagnostic for postural orthostatic tachycardia syndrome. Now, there is more to the tilt table test than what I have showed you. In fact, part of the tilt table test depends on what kind of pharmacologic agents you give the patient, but I give you just this general overview, and I'll also give you the caveat that I just learned about this from reading. I have no actual experience with it, or in person. So no training, just all of this from reading alone. Let's talk about treatment now for reflex syncope. For reflex syncope and for orthostatic syncope, your vignette, the answer is going to be counter pressure maneuvers. This is going to be almost always true for orthostatic syncope, and it's going to be true for half of reflex syncope. The vasodepressor reflex syncope counterpressure maneuver is the answer. For cardioinhibitory reflex syncope, it is not going to be as helpful. So this goes off of the basic knowledge that you typically have a prodrome with neurological causes, and you don't have a prodrome with cardiovascular causes. So if you have a prodrome, you can feel the pre-syncopal episode. That means you need to tighten your hands and your legs, and you need to even possibly squat down, change your position, lay down if you need to, and increase the pressure around the veins that are increasing the preload to the heart. So you're using your muscle mass to do what your autonomic nervous system should have done in the first place. Some things will suggest to add salt and fluid to the diet. Some things will suggest midodrine. I'm not really sure how beta blockers work in this treatment, but they are recommended for patients that are over 40. I know that with beta blockers over long term, there is an increase in inotropy, an increase in cardiac output that is sort of paradoxical, but it does happen. So if there's a vasovagal, right, this is a subtype of reflex syncope. If it is vasodepressor, all of this stuff above counts. If it is cardioinhibitory, you can try all that stuff up there, but in general, you want to do pacing, cardiac pacemaker. Now, this is true for patients that are over the age of 40. I think the actual number is 42 in the United States. For some reason, cardiac pacemaking does not help people younger than 42, and that is a mystery in the literature. Now, I said it doesn't help patients in the United States. It doesn't help people with a neurologic cause of syncope that is cardioinhibitory. A person who has bradycardia under the age of 42, for cardiogenic causes, they would be helped with a pacemaker. A person that has POTS, you can try things like fludrocortisone, which is an aldosterone mimic. You can use propranolol, midodrine, clonidine, alpha-methyl-dopa. All of these are assuming there are no contraindications. Regular exercise program. This is the number one recommended thing for POTS. Now, treatment for cardiovascular causes, you're going to treat the arrhythmia if one exists, and there are a number of ways to do that. One of them would be pacemaker, one of them would be defibrillator. Or you're going to correct the structural abnormality, vascular surgery, for example. But that's very simple. If it's cardiogenic, you correct the arrhythmia or you correct the structural abnormality. I don't even think I need a slide for that, I hope. Change pace really quick. I'm trying to fit a whole bunch of little random details into this last lecture because a lot of little random details exist. One thing is there's a rare cause of syncope that I didn't really mention anywhere else. It looks like vasovagal on the history and physical exam, but like cardiogenic causes, there's no prodrome. When you check the plasma adenosine level, it seems to be decreased. Or it doesn't seem to be decreased, it actually is decreased. So these people respond to regular, I believe, weekly injections with adenosine. I don't understand the pathophysiology. I haven't looked into this. I just know it's a rare cause, okay? So you can take that for what it's worth. This is not something you would probably be working up as a primary provider, but at a tertiary facility that is dedicated to syncope, they would probably be more likely to know about this and to work this up. I actually threw references in this slide, this PowerPoint twice. We're going to skip this page and come back to it at the end. So now I want to go through history, physical, tests, things that you would do if you had this person show up. Let's suppose that you're on call for inpatient and you had someone show up in the ED and the emergency department believes, hey, this looks like maybe a person could be in serious danger and I think we need to admit them. And now it's your turn to go do the history and physical and the workup for this patient. So things you're going to look at on history and physical, do they have an arrhythmia, of course? Is it sudden? Was there no prodrome? Was it during exertion? Did they have palpitations? Did it happen with exercising? Was there dyspnea, angina? Or is this common thing that happens after a very, very regular, like every time they go pee? Or maybe this is the first time it happened, but did it happen while they were going pee, while they're going poop? Did it happen at the end of exercise? Something I really didn't mention during the orthostatic talk is there's something that's associated with it called a coat hanger headache. What this is, if you can imagine, here's the back of a person's head, here's their shoulders, and they have a headache that goes down the occiput and then kind of goes over both shoulders and the neck. And you can see how that might look like a coat hanger. Another thing you would say, like for neurologic causes, just like there's a prodrome, they tend to also have symptoms after the thing has resolved, after they come back to consciousness. They have this uneasy feeling for the rest of the day. With medication lists, you would look for things like vasodilators. You would look for things like antidepressants and opiates. For structural heart meds of any kind, but like specifically antiarrhythmics, is the patient taking dofetilide, for example? What's their potassium level? For the past medical history, well, what is your heart past medical history? Do you have any history? Have you ever had an MI or a bypass? Now, this is interesting. Just, I think, August 16th, just last month, 2018, New England Journal of Medicine, it was one of their cases, I think case maybe 21 of 2018, somewhere around there. They had a case of syncope, and this actually happened because there was a saphenous vein bypass graft that a person had about 10 or 15 years ago. They had the saphenous vein bypass graft, and the saphenous vein became very dilated, and it started pressing against the ventricle, preventing it from completely getting filled. And then in the state of being drunk on alcohol, dehydrated, vasodilated, the person had syncope. So he had a mix of structural and orthostatic syncope. For reflex, you'll say, do you have a history of neurodegeneration? There could be neck surgery for orthostatic. Family history of sudden death or family history of neurodegeneration. Now, in review of systems, the cardiovascular causes can occur standing or supine, whereas the neurologic causes almost always have to be standing or at least sitting up, never while supine. For reflex, was there a recent meal because you're activating the parasympathetic nervous system in the GI tract? Was it at the end of exertion? Did it occur supine? Orthostatic, was there a recent volume loss, diarrhea, vomiting, fever, fluid restriction? For cardiovascular causes, you would see things like pitting edema, JVD, a hepatojugular reflex. You may feel or auscultate an irregular pulse. There may be a diastolic plop, a new bruit, hypotension or hypertension. Again, pulsus paradoxus, pulsus parvus et tardus. There may be a difference in the blood pressure from one arm to the other. If there's a PE, there may be tachypnea and tachycardia. For reflex syncope, something that you may do on physical exam, I don't know if it's recommended against or for example, if there's vasovagal syncope with exposure to some emotion, you may be able to try to re-trigger that emotion and see if the person has a syncopal episode. Again, look in the guidelines and see if that's recommended. I'm honestly not sure. If orthostasis is suspected, you can actually do the orthostatic blood pressures. If dysautonomia is suspected, you can check the pupillary reflex, ask about constipation or erectile dysfunction. And then last of all, you can get clues from your other labs and studies. For example, you may want to get a BNP. You may want to get a cardiac event monitor. A transthoracic echo is often the most commonly thing used in the initial workup for structural causes. Carotid ultrasound, although it's done regularly, it's recommended against. Usually reflex and orthostatic are identified from the history and physical alone, and you don't need any further testing. But when it's unclear, tilt table testing is really good. Also, event monitors, if you're really not certain. There seems maybe there was some bradycardia and you need an event monitor. You can look also at lab findings. Was there any indication that the person was dehydrated? Also, is there evidence of some other feature that would cause dysautonomia? Like you can look at SPEP and say, did they have multiple myeloma? Some places will do nerve conduction studies. It's not really recommended in the initial workup, but you can get cardio and neuro involved and they can do those things as well. You can check for things like syphilis. Honestly, bottom line, orthostasis is to do a beat-to-beat blood pressure monitor. So the 2017 American College of Cardiology, American Heart Association guidelines said that it's considered Class 1A evidence to do a thorough history physical and to get an EKG or an ECG. On most diagnoses, you're going to know the answer at this point. So 1/3 of cases of syncope are undiagnosed, but out of the 2/3 that are diagnosed, half of those, or 1/3 of the total, is going to be diagnosed from the history, physical, and ECG. Now, the next thing is you can do a risk stratification score for people that have cardiac causes that are suspected or otherwise. This is a level 2B with a level B, level of evidence of B. So risk stratification score, there's many of them. You can kind of pick and choose which one you want to be your favorite. But in this guideline, this 2017 guideline, there's a table 5. Table 5 gives you risk factors for short and long-term morbidity and mortality. Identifying factors in that table is considered level 1A evidence, or rather a 1A recommendation, a strong recommendation rather. Now focusing on 2A and 2B level with a B level of evidence, use targeted blood tests. Do not just throw a slew of labs at somebody. For example, you probably don't need a BMP unless you're looking to see if they're dehydrated. A CBC could point out anemia, for example, peptic ulcer disease being a risk factor. But this level B evidence says do not just throw labs at somebody, use targeted labs. Looking down here, troponin is useful only when you suspect an MI. Otherwise, what you're going to do is you're going to find yourself trending troponins on somebody that has AFib, for example, and you're giving yourself more work than what you need. When a cardiac etiology is suspected, CT and MRI may be very useful. I would say start with the TTE, and you may even want the TEE, but it's a 2A. As far as labs go, the BNP, it's really uncertain how useful that is, but you can get it if you think it will help. And when you suspect vasovagal syncope, but it's unclear, use a tilt table test. And then a person that has syncope with exertion, if you think that bradyarrhythmia is suspected and not tachyarrhythmia, you may want to consider doing a stress test. That's also very dangerous. You have to have the right facilities. If neurodegenerative disease is suspected, you can refer for autonomic evaluation. So you have a patient come in and they have syncope, and the question is, do you work them up inpatient or outpatient? The answer to that comes from answering one question: is there a serious medical condition present? If there is, inpatient evaluation. Most of the time, cardiac syncope or suspected cardiac syncope is in itself a serious medical condition. However, there are selected patients that can be worked up outpatient setting. When you're working a patient up, if the initial evaluation, you do a history, physical, EKG. That's your first step, history physical EKG. If it's clear, nothing else needs to be done. Second thing is, it could be very suggestive but somewhat unclear. If it's completely unclear, you can do targeted blood testing. However, if there's some kind of suggestion in the initial workup, say for example, it happened when the person stood up, or it happened when they went to the restroom. So if the suggestion is orthostatic hypotension, you can do a referral to autonomic evaluation. If it suggests reflex syncope, you do a tilt table test. If it looks like there's some kind of structural cardiac abnormality, you can do a TTE. You can also do stress testing if it looks like a bradyarrhythmia. There's electrophysiological studies that are available. MRI and CT are also available. But if it clearly looks like an arrhythmia, and that arrhythmia, then you want to do a monitor, like an event monitor or something like that. And the kind of monitor you use will depend on the frequency of the event. For example, you can have an implantable cardiac monitor. You can also have an ambulatory external cardiac monitor. And suppose your evaluation, you did your tilt table testing and you had reflex syncope, then what? The primary treatment for that will be counter pressure maneuvers, and you can also increase fluid and salt intake. In the event that you still have recurrent reflex syncope, midodrine would be your next go-to medication, and then there are other medications that are also available. And I hinted at this earlier. Suppose you find out you have orthostatic hypotension, and that is causing your orthostatic syncope. You ask yourself, is it due to dehydration primarily, drugs primarily, or primarily neurogenic? If it's due to dehydration, it still could be primarily a drug, for example, Lasix. And in that case, you could change when you give the Lasix, how often you give it, how much, or you could completely withdraw it. The other option is to increase salt and fluid intake. Again, medication removal if it's primarily drugs. And then if it's neurogenic, water intake is the main answer. So let me point this out. Unless the orthostatic hypotension is due to medication, the answer is going to be take in water. If it's neurogenic in origin, you can try compression garments. You can try counter pressure maneuvers like with reflex syncope. You can try midodrine. You can try several other pharmacologic agents, but the primary way to treat this is going to be acute water ingestion. Here are the major guidelines whenever you want to find out if there's anything updated. I relied heavily on this 2017 American College of Cardiology, American Heart Association guideline for the evaluation of patients with syncope. And of course, you can look at the journal article online. There's the PDF right there. There is a newer 2018 guideline. It's a European guideline. It is basically mostly the same as this 2017 article. And then, of course, if you're wanting to look at the tilt table test, this 2015 guideline is a good resource for that. Now you can see on this link I'm providing, it will work for anyone who is on the University of Missouri campus. It's a proxy link. If you are not on the University of Missouri, you can search for this PMC number and that will get you the best link you have available. The same thing goes for this one up here. You can search for this PMID number. However, for the American Heart Association journal, no proxy was used.